A very good morning to all the faculty members and the delegates. We are from Chellaram Diabetes Institute and we will be starting our 5th International Diabetes Summit, which would be conducted virtually because of the COVID pandemic. The conference would be today, tomorrow and day after tomorrow, that is 12th, 13th March. I am here from Banting Hall, Dr. Vedavati Purandare, consultant physician from Chellaram Diabetes Institute. We will start with our first program and we will stick to the time. To have the first lecture, we will listen to Dr. R.M. Anjana, and the topic is Novel Clusters of Diabetes in Indians. Dr. R.M. Anjana is a leading diabetologist and managing director at V. Mohan Diabetes Specialty Center. She is known to all of us, and we welcome Dr. R.M. Anjana to IDS 2021.
Great pleasure to be a part of the International Diabetes Summit 2021. My special thanks to Unikrishnan sir for giving me an opportunity to be a part of this virtual symposium. So today I'm going to be talking about novel clusters of diabetes in Indians, and I have no conflict of interest to declare. So we'll start by asking the question, are all type 2 diabetes the same? And I think the obvious answer to that would be, of course not. There is so much of variability in type 2 diabetes based on BMI. So someone who has thin diabetes with young age of onset is completely different from someone who has older age of onset. Till date, we do not know why some people respond to some medications while others don't, and why some of us develop some complications while others do not. So there is a lot of variability of type 2 diabetes, and I think that is what this talk is trying to address. So in the West, this is data from Professor Leaf group from Scandinavia, who published this paper on the novel subtypes of adult onset diabetes and their association with outcomes. And what they showed is that they took about 9,000 patients from the Scania cohort, Sweden, and they studied 6 variables, which is the GAD antibodies, the age at diagnosis of diabetes, BMI, A1C, and HOMA beta and HOMA IR. So these are, HOMA beta is a measure of insulin secretion, whereas a measure of insulin resistance is HOMA IR. So they took these variables, and of course they replicated it in 3 independent cohorts, as mentioned here, small numbers, most of these. And what they found is that we were able to cluster diabetes into 5 major types here. So of this, the first group is called SED, and that is type 1 diabetes. So we won't be talking about that anymore for this lecture. But let's talk about the 4 clusters of type 2 diabetes. The first which he has was called SID, or the severely insulin deficient diabetes. So again, this is a GAD negative, low BMI, early onset diabetes with severe insulin deficiency. So that's the first type. Then they had the third, which is insulin resistance and high BMI. Then they had obesity with no insulin resistance. And the last is MARD, or mild age-related diabetes. So these were the clusters which were described in the West. So then we ask, okay, can this be applied directly to the Asian Indian population? And one must keep in mind, there is something called the Asian Indian phenotype. So what is this? We Asian Indians have differential responses to a lot of drugs and have differences in our type of diabetes itself. So we have a greater ethnic susceptibility. You know, the low in fact Indian, which is the low birth weight hypothesis. So this means that even at lower BMIs, we are able to get young onset diabetes and fairly severe diabetes. We also have increase in insulin levels. We have a very characteristic dyslipidemia with low HDL, high triglyceride, and high in the small dense LDL. Decrease in adiponectin levels, increase in visceral adiposity, and increase in the inflammatory markers. So all of these give us a specific susceptibility to premature cardiovascular disease and type 2 diabetes. So with that in mind, we then started this collaborative study between the University of Dundee in Scotland and MDRF, This was funded by the National Institute for Health Research, NIHR UK, and the project is called INSPIRED, which stands for India-Scotland Partnership for Precision Medicine in Diabetes. So this is one of the things we did. So we took the Scandinavian cohort, and this is the cohort as is. So let's look at the first top here. And what you see is that in the SID group, look at the BMI, it's 28, yes. In the insulin SIRD group, it's 33, and that's what you would expect. Obese group is even higher at 35, and the MARD group had a 27, which was the lowest BMI in their cohort. Age of diagnosis was obviously highest for the MARD group, and it was about 67 years. A1C was higher for the deficient group, you would expect that, and it was best in the MARD group. And you see the HOMA beta, of course, was least in the deficient group and highest in the SIRD group, the insulin-resistant group. And same thing is shown here. Insulin resistance is higher in the resistant group and least in the deficient group. So this is what you would expect, and those clustered pretty well in their population. So we took the exact same variables and then tried to cluster it onto the Indian population, and that is what is shown below in the tabular column. So now let's take a look at it. So BMI, if you look at it, it was 24 for SID, and that's what you would expect. But look at our obese group, or MOD. They were actually not very obese at all, whereas our SIRD group had a higher BMI, the MARD group had higher BMI. So something didn't sit quite well when this clustering was applied directly. Similarly, when you look at HOMA beta, HOMA IR, etc., there were things that were not really sitting too well. For example, the insulin-resistant group had 4.9, and the deficiency group, if you see, the HOMA beta, it was quite high in the MARD, which was not something that you would expect in this population. So what I'm trying to say is that when we tried to absolutely replicate directly, this wasn't sitting very well, and we found that we actually couldn't replicate it as is. So this led us then to do our own replication, and this was then published in July 2020 in BMJ Open, where this is the paper. It's called Novel Subtypes of Type 2 Diabetes in the Association with Microvascular Complications. So we took the Dr. Mohan's database with about 19,000 individuals with new onset diabetes. So they were diabetes duration less than 5 years. So new onset diabetes with duration less than 5 years. 19,000 individuals with type 2 diabetes were included for the study. We had 8 variables as compared to what Leaf Group had. We had more, and these variables were dependent on the Asian Indian phenotype. So let's look at it. We had age of diagnosis of diabetes, BMI, waist, A1C, but we had triglyceride and HDL. As I showed you, those are important. And we had fasting and stimulated C-peptide. So these were the ones which we chose for our clustering. And once we did that, these were the groups that we found. So immediately what you see is that 2 of the groups we could replicate with Leaf groups. So we were able to do the SID. So this is the severe insulin deficient diabetes, similar to what they showed. This is early onset diabetes, thin people, low BMI and waist, low C-peptide. Okay, so that is the first group. Then we also found that the last group, MARD, is mild age-related diabetes. This was also replicable. So these were milder diabetes, high HDL, etc. These 2 were replicable. But we also found we have 2 new clusters which were being described for the first time in the world. And these are called IROD, which is the insulin-resistant obese diabetes. So it appears that in our population, obesity is linked to insulin resistance and vice versa. So we're not able to split. There's no insulin resistance without obesity, and likewise for the other. So we were not able to make 2 groups out of that. This clustered into one in our population. Similarly, I think the most important group here, which what we defined, is called CIRD or CIRDD. This stands for combined insulin resistant and deficient diabetes. So here you have a combination of SID and IROD. All of the features of CIRD are in between SID and IROD. So there is insulin deficiency, plus there is insulin resistance and obesity. So everything is in between. And if we look at the next tabular column, this is what will show. So age of diagnosis. So we found the highest ages of course for MARD, but they're much younger. If you remember Leaf groups, they were 67. Here at 50, 55 itself, we find that they're going into MARD. For the BMI, of course, BMI and waist, we look at that together. It's the lowest in SID, like you would expect, and highest in the IROD. Glycated hemoglobin was highest in the insulin-deficient states, so that includes both SID and SIRD. Triglyceride was very high in the SIRD population. HDL was best in the MARD. And if you look at the C-peptide, you'll see that the deficiency groups have the lowest, whereas the insulin-resistant groups have the highest. And that is what you would expect. So we've now found a clustering that is beautifully kind of falling into these categories, and thus we were able to identify this. So here we have looked at it by male and female, by gender, to see if there were many differences, and suffice to say that there was nothing significant between the sexes. We then looked at whether, so remember I said we selected newly onset diabetes with duration less than 5 years. So we then looked at whether duration less than 3 years or duration less than 1 year affected the clustering, and we found that it was pretty much the same, only decimal point changes were there. But then you may ask me, okay, this is a clinic-based study. How is this generalizable to the whole of India? And thus we try to replicate or validate this with the national ICMR INDIAB study, which you know is a national study on diabetes and complications in every single state of the country. So this is the study, and from there we had these variables. We had age at diagnosis, BMI, waist, A1C, triglyceride, and HDL. So we had 6 of the 8 variables. So we utilized that, and we were able to cluster into the INDIAB population. Now let's look at what happened. So here you see the age at diagnosis was 55 years, and that was MARD for men. For the original cluster was 50, here it's 55. BMI is lowest in the SID group. The circles are a bit wrong, but so please forgive that. But the BMI, as you can see, is lowest for the SID, and then highest for the IROD, similar for waist circumference, exactly the same thing which we saw in the clinic population. The glycated hemoglobin is 10 and 9. Again, the highest are for SID and SIRD, just like we found in clinic. Triglyceride was higher, HDL was highest in MARD. So we have the exact same replicable finding that we are able to do in a national data set, indicating the replicability and stability of these clusters. So yeah, so we were able to replicate this, and the stability index was 0.75. So what is the clinical relevance of this clustering? Well, these are the Cox hazards ratios for microvascular complications across the clusters. So if you look at SID, it has a hazards of 1.56 for SID. So that's pretty high, and that is statistically significant. Similarly, the SIRD group has for retinopathy. So for retinopathy, you're seeing the insulin deficient groups being statistically significant. But now let's move on to nephropathy and CKD. So here the definitions are different. CKD is with GFR, and the other one is proteinuria. So if you look at nephropathy, here we had statistical significance for only the combined group, the SIRD group. And for GFR, we had IROD, and that would be expected. But look at the number for SIRD, and look at those hazards ratios. It's like twice that higher. So this goes to say that that's why I was talking about the SIRD being exceptionally important, because the risk for these microvascular complications, both retinopathy and kidney disease, is very high for this group. So this is the time to reaching treatment goal, A1C less than 7. So it's best for the MARD group, as you would expect, and worst for the insulin deficient groups, as shown here. So I'd like to summarize by saying that for the first time in India, and indeed South Asia, clustering was done in individuals with type 2 diabetes using 8 clinically relevant variables. We had 4 replicable clusters, 2 of which, the SID and the MARD, were the same as the Scandinavian clusters. However, we identified 2 novel and unique clusters, the IROD and the SIRD, of which the combined SIRD group is of particular importance as it is characterized by difficult to control hyperglycemia and increased hazards of kidney disease and retinopathy. So in the clinic for the GP, how is this useful? If you just have 6 clinically relevant variables like the ones listed here, and you are able to enter this, then we are able to, with a fair degree of accuracy, tell you what percentage each individual patient has of being in one of these 4 groups, with a percentage calculator for complications. So this will be useful to identify who we need to start insulin in, who we can, we have to be really aggressive with therapy and things like that. So I think this is the future of precision medicine in the diabetes clinic. Thank you. Good morning.
You have really enlightened us on the various types of diabetes, that is SID, SIRD, MOD, and MARD. And we also have listened to Dr. Lee Group, who is basically a father of precision diabetology. And this was a wonderful lecture. I'll just check in the chat box. Do we have any questions? Dr. Anjana, are you there?
Yes. Do I hit start my video?
Sure, sir. So the next lecture would be by Dr. Roger Maze on AGP and diabetes, focus on transition to CSII and type 2 diabetes management. We are fortunate to have you, sir, in our virtual IDS. Dr. Roger Maze has a lot of experience in AGP, and he has done a lot of work in AGP. He is director and founder AGP Clinical Academy in a renowned hospital in England. He is recipient of Award for Distinguished International Service in the Cause of Diabetes by ADA, and he is professor of University of Minnesota Medical School, and he has also authored AGP Foundations and Applications in Clinical Practice. Over to you, sir.
Thank you. And thank you for the kind invitation to this meeting. I believe you have my video to show. There we go. Organizers for their kind invitation to present at this meeting. My subject is going to be ambulatory glucose profile and diabetes, focusing on the transition from continuous subcutaneous insulin infusion in one case and management of type 2 diabetes in the other, and how ambulatory glucose profile is used in these endeavors. I want to begin with the notion that the promise of CGM changed diabetes. We now have available to us accurate and reliable glucose data upon which we can make decisions, and we can base this on evidence provided by the patient without bias. The purpose and use of the ambulatory glucose profile in practice is to use this data to best represent the diurnal glucose patterns of individuals with all types of diabetes in order to detect the key deformities or disabilities of the individual, the key characteristics of glycemic control. I want to introduce the AGP as the new standard of care for diabetes management and present 2 case studies to show you how this is put into practice. The purpose of the ambulatory glucose profile, when I developed it in 2008, it was, in my mind, a way of showing glucose values that in the aggregate previously were represented as an average or a standard deviation. And I wanted to show it in such a way to assist in clinical decision-making so that it could characterize the underlying dysglycemic patterns, measure glucose exposure variability and stability, and at the same time, allow us to accurately assess the risk of hypoglycemia. As you know, continuous glucose monitoring, when used appropriately, can be provide data for every single day that a sensor is being worn. And as it's continuous data, all of the data points can be joined together in a curve. What you'll notice here is when you look at these individual days, they don't seem to be the same as the next day, with few exceptions. And if you were to characterize all of these days, it would be very difficult going beyond the individual days and their characterization. And you can see when I superimpose the second week on the first, how different the glucose patterns are. Now, some of the manufacturers, when CGM was first developed, thought the best way to represent these differences was to plot each day as a separate color over the 14 days in which the glucose was being measured. I, however, wanted to use both a mathematical and physiologically correct way of representing glucose control and the different underlying patterns. And so I produced the ambulatory glucose profile, made up of 5 frequency distribution curves. The curves represent the median, the interquartile, and interdecile ranges. So this allows us to measure the key characteristics of glycemic control. The first of which is glucose exposure. And exposure traditionally is measured as area under the median curve. However, when you have this amount of data, summarizing it as a single area does not do it justice. As you'll note, in the early morning hours, the area remains within the normal glucose level for an individual. But by midday, the individual is experiencing hyperglycemia. So we're in excess glucose. Some have used the terms time above range, time in range, and time below range to represent these differences. I prefer to use magnitude, duration, distribution, and frequency to describe the glucose exposure because it's different for each different time period. Glucose variability is a way of looking at the variation from day to day at any particular time period, as shown here overnight and in the early morning hours, and again using magnitude, frequency, duration, and distribution to give us a better understanding of how wide the spread is. The overnight spread is fairly narrow when you compare it to the spread between 10 and midday, 10 a.m. and midday. Glucose stability looks at how stable the glucose levels are throughout any given period of time. And you could see here how unstable glucose values are in this particular case, with glucose ranging as high as 3 millimoles from its base level. Hypoglycemia and low glucose is much more easily measured. However, it still needs to be defined by duration and frequency. And as you can see here, although 13% of the values are below the target being 4.5 millimoles, that's not hypoglycemia. In fact, this shows how many glucose values are below the hypoglycemic demarcation of 3.9 millimoles per liter. In 2021, the standards of medical care in diabetes were published by the American Diabetes Association. In these standards, you will see that ambulatory glucose profile should be considered as the standard printout for all CGM devices. So, in the approximately 12 years since it was introduced, AGP has withstood the test of time, and its application in clinical practice will show you why it has been seen as such a valuable tool. In this first case, we're looking at a 55-year-old, a significantly obese individual with type 2 diabetes for 10 years, treated with DPP-4, metformin, and sulfonylurea because of significant hyperglycemia. You can see from his glucose profile that his glucoses are way above the normal range. They're in significant hyperglycemia throughout the day and overnight, and there is virtually no hypoglycemia. Because of the AGP, we were able to understand what was happening with the individual and that he did not risk any hypoglycemia. And therefore, we decided to drop the DPP-4 and the sulfonylurea and add a GLP-1 in order to narrow the variability before we dealt with glucose exposure. And as you can see, it was very effective. The use of the DPP-4 along with metformin was able to produce 80% reduction, a significant reduction in glucose variability. However, 80% of the values were above target range. To lower it within the target range, we began insulin therapy. And the insulin therapy, as you can see here, was very beneficial. Still with no hypoglycemia, we managed to lower the glucose level to within the normal range, providing an estimated A1C of 6.2%. We allowed ourselves a little more adjustments with the long-acting insulin, and the final results are shown here. On the left is the baseline, and on the right is the final AGP. On every measure, this individual improved. The time in range increased from 8% to 91%. The time above range reduced from 85 to 9%, and hypoglycemia from 7 to 0% of the time. My second case is from multiple daily injections of insulin to pump in an individual with type 1 diabetes seeking to tighten her glycemic control before conception. And if you take a look now at the glucose profile, you can see that she had significant variability, which may lead to anomalies in a developing fetus. So it becomes incumbent to tighten glycemic control well in advance of conception. And so we used the first AGP to define the problem. We identified some hypoglycemia overnight. We identified the glucose variability as our target. We set the therapy based upon the information we had from the patient in terms of their use of insulin, and the results are shown here. As you can see, we improved control considerably. Virtually all the values were now within target. We narrowed the variability, and this puts her in an excellent position in preparation for conception. So from MDI to pump, this was the MDI profile on the top, and this is the pump profile on the bottom. And you can see using an AGP not only enables us to visualize the dysglycemia, but to determine whether we resolved the underlying problem. And as you can see here, that's exactly what we did. In 2021, as I mentioned, after 12 years, the American Diabetes Association accepted AGP as the standard of care for CGM. It's incumbent upon all of us to use this technology to improve clinical outcomes. It allows us to have a diurnal glucose profile, to measure exposure variability and stability, and to reduce the risk of hypoglycemia. Thank you very much. I want to thank the organizers.
Thank you so much, Dr. Roger Maze, for the excellent presentation on AGP. And we were really amazed to see patients' HbA1c above 10 becoming 6.2 with GLP-1 analog and a long-acting insulin. Sir, my question to you is, we have seen that how exposure and glycemic variability we can monitor on AGP, but the indices of glycemic variability for a clinician like me, standard deviation coefficient of variation is okay, but other indices like Conga and MAGE, they are little difficult for us to measure on a day-to-day basis. So do you think that these indices are there only for research purpose, or they should be really used in a clinical practice, in day-to-day clinical practice?
Personally, and I want to congratulate the previous speaker, because she was focusing on what is the new field of medicine, precision medicine. And if you take a precision medicine perspective on the management of diabetes, any of these standardized measures like NCONGA, standard deviation, average, they're just too broad. They don't define the individual characteristics that lead to the precise treatment. Just like type 2 diabetes is clustered into 4 different types, management of diabetes cannot be done by HbA1c, by NCONGA, by standard deviation, by mean glucose. These are all too broad a measure. They don't tell us, is this occurring in the morning or overnight? They don't tell us, is the therapy really working in a way that mimics normal glycemic control? Or is it simply lowering HbA1c by putting the patient in severe hypoglycemia a significant amounts of time? So my perspective is very simple. As soon as possible and feasible, put a patient on continuous glucose monitoring and use AGP to guide the clinical decisions. Of course, if they have type 2 diabetes, identify which cluster they belong to first, because you could determine early on what treatments are effective. For some of these patients, insulin therapy is going to be the initial treatment. But as you know, in type 2 diabetes, we often wait a very long time and try everything else first. Well, with precision medicine, not only can you determine which therapy you should use first, but also, and most importantly, using CGM, whether that therapy is effective and how to adjust it.
Dr. Anjana, thank you for a wonderful talk, and it's very nice to see you on the virtual podium, and Dr. Maze as well. So would you like to respond to Dr. Maze's the question of how we can work on unique clustering in future, and what would be the role of newer glucose analytics in this?
Yes, so thank you, sir, for having me. That's the first thing I should say. This is a good start to a very good meeting. Thank you very much. It's a pleasure to be here. And I really enjoyed Dr. Maze's talk on CGM. I'm in complete agreement with whatever he's saying. So regarding the clustering and the use of this in, let's say, clinical decision making. So as I was saying before, and Dr. Maze was pointing out just now, so when an individual patient, how is this helping us sitting in the clinic? So when an individual patient walks into your clinic, the idea or the dream perhaps would be in the near future, could be that maybe with a point of care device, okay, we are able to genotype, because that's what we're doing right now as a next step. We're trying to genotype people into these clusters. So with a single drop of blood, we can possibly say that, okay, you are possibly belonging to the SID variety or the combined variety. You are someone who has a potential risk for retinopathy or nephropathy. You need to go on insulin early. You need to be, or you're someone who's, able. At the current time, we are able to do this through some risk predictors, some algorithms, But I think in the future, that would be the future of precision medicine, not just here, but all over the world. And that's where things like CGM of any type becomes essential, because that kind of tight control and intensive glucose control, I think, is finally what's going to get us to good levels of care.
Thank you so much, Dr. Anjana. Can we have a chat box, please? Dr. Anjana, there was one question for you.
Yes.
As we have categorized diabetes patients into 4, one
Yes.
question is there, should we treat SID patients only with insulin and sulfonylurea and prevent giving them pioglitazone and metformin, which are insulin sensitizers?
So goes to say, well, in biology, there's never any absolute answer to anything. But from the data that we have and the science that we have, these are people with insulin deficiency. So it tells us that they're going to respond best to insulin. So we're going to get the best results with insulin, with say, and maybe less effect with the sensitizer, because their problem is not insulin resistance, it's a deficiency problem. So that's what it tells us. Now, having said that, the individual patient variability could always be there for us, but this is a very good indicator for the clinician as to which direction he should be going in. And if I was somebody treating someone with SID, I would definitely pick insulin first and all of the other secretagogues.
Okay, thank you. And any study of euglycemic clamps in these novel clusters?
No, I'm sorry. We haven't gotten there yet. Clamps are difficult to do, as you know. We haven't gotten there yet. But what we're doing right now and is what we're looking at therapeutics, actually, at the current time. We're looking at drug response in the clusters. So the absolute answer to your question should be out in a couple of months as to which. Common sense tells us things right now, but we don't have scientific evidence backing it. But right now we have data from about 17 states in the country from different collaborators. We're pooling this, we're reclustered, and we're looking at drug response among the clusters to define which cluster, which drug works best. That is one part of it. The other part of it that we're going to do is look at the genetics. We're genotyping these people to see whether, like I said before, we can predict even before, what kind of diabetes and what risk of complication through the genotype. And early on, even, just as soon as one is diagnosed, which drugs to put them on. So that's the overall hope.
There's one question from the audience for Dr. Maze, and the questioner asks that, in future, do you think like a fingerprint, there's going to be a glycemic bioprint which combines with artificial intelligence and behavior analytics to develop unique glycemic patterns?
In the future, on one fingerprint, that would be rather difficult. That would be rather difficult. I don't think that is near. And again, there is a tendency in medicine to try to push everything into simplicity. If you can make it more simple by one number, one finger prick, one type of diabetes, and that solves everything. But as my co-speaker has said so eloquently, there are 4 types of type 2 diabetes, and each one demands a different form of treatment if we're going to benefit those individuals. And the principle of precision medicine, which I hope Dr. Basu, who's on your presentations, will mention as well, the principle there is to identify the individual differences, not to make people common, but make them individuals. So one day, hopefully, we will have a better way of identifying the type of diabetes, identifying the right therapy initially, monitoring it quickly enough to determine, I think through CGM or similar technology, that the person is now in safe, better control that will reduce the risk of complications. As you saw, some groups had much higher complications than others. And all of that is very expensive at the other end. This is very inexpensive medicine compared to treatment of the complications. So we have to refocus much of our attention on this first part, identifying the uniqueness of the type of diabetes and then treating it accordingly.
Okay, quick question for Dr. Anjana. In Dr. Group's paper, he alluded to mild obesity-related diabetes and mild age-related diabetes, and that public health resources not be used to treat these subgroups. Now, if you remember, as medical students, we've been told that there is nothing called mild pregnancy, for example. There's nothing called mild diabetes. You're either diabetic, you have diabetes, or you have no diabetes. So, what is your opinion about? Are there some clusters treating them less aggressively? I think your findings are different from the international cluster. That gives us very unique Indian perspectives. Your views on that, please.
So for us, as a phenotype, we have not found obesity alone independent of insulin resistance. For us, we find that goes together. So that is the first thing. Now, when you say mild, we do have the MARD group, the mild age-related diabetes. So here we're not talking about just being pregnant or not, diabetic or not. I think we're referring to the ease of control of glycemia. That's what we're talking about. And when you have something that's age-related, when you have something that you don't need to be as aggressive in someone who's like, say, 60 or 70, as you would be in someone who's 35. So I think that is the mild form in our clustering. But I think what for us really matters, the obesity part, sir, as you know, is less important. For us, the insulin deficiency seems to be like a larger, major, more difficult to treat group, number one. And number two, the novel group, which is the combined group. So we have this double trouble here. So we have a baseline deficiency on which we start having this insulin resistance, obesity coming in because of lifestyle and things like that. And that, I think, is potentially preventable through our public health programs and all of that. And I think that's where we need to kind of put in focus.
Thank you. Dr. Veda will now take you through the rest of the questions. Yes, we have lots of questions coming in. Dr. Veda, over to you.
Thank you, sir. Dr. Anjana, there is one question for you. In SID patient, do we need to check GAD antibodies? Is one of the
that
questions.
is a very common question I get. People keep confusing type 1 with this. So I just would like to say this isn't type 2 diabetes. So we are talking about people who we have ruled out as type 1. And in order to do that, if you have young onset diabetes, and you would obviously suspect type 1 if the sugars are high, you would have done the C-peptide, you would have done the GAD, you would have done all of that if you had suspected type 1, right? And once you've done that and then you've ruled it out and then you're looking at type 2, young type 2, this is a subclassification of type 2 diabetes and it has nothing to do with other types of diabetes.
Thank you so much, Dr. Anjana. So there is one question, Dr. Roger Maze, for you. In India, we have Libre Pro and Liber for AGP. So which is better as per your clinical experience, sir?
Could you repeat the question again? Someone was right behind you. I'm sorry.
Yes. So, in India, sir, we have in clinical practice, the available AGP sensors are Abbott Libre Pro and Abbott Liber.
Oh, I see. Okay.
Which sensor in clinical practice?
I'm sorry. Now I understand. The sensors are essentially the same. The basic difference is if you have individuals who you think will change their behavior, who may be nervous, who may get too excited, the Pro is better because they don't see any of the numbers. They don't have any feedback whatsoever. Only the physicians and their staff get the feedback, so there's no bias. However, if you have cooperative patients who you want to change their behavior and you want them to learn while they're monitoring, then obviously the standard form is much better because it gives you immediate feedback. And the newer versions are even better yet. So you have them, they're accurate, they're reliable. The newer versions, I believe, have alarm settings on them as well. So for type 1 diabetes, they're very effective in warning about hypoglycemia. But in all, either one is better than SMBG. That's for sure. So if you can use either one, it's much better. I would like to comment on one thing about mild type 2 diabetes, because I've been asked about that when we produce AGPs. So we studied normals, people without diabetes. People without diabetes have a very characteristically flat AGP. 5 parallel lines, variability no more than 1 or 2 millimoles. That's what protects you from kidney disease, eye disease, heart disease. So our role is to mimic that by treatment. So any person who cannot match the normal profile is at risk for developing complications. And so therefore, we need to figure out the best way to get them back into this normal pattern. Now that we know what normal is, and we can identify that by targeting the therapies, as my colleague has said, depending upon the cluster in which you belong, to reduce the risk, but to always begin with the notion that any form of diabetes is defined as an abnormal AGP. Think of it that way. Normal AGP, then you're fine. Abnormal, we've got to do something about it.
Thank you so much, sir. Last question for Dr. Anjana. AGP study in 4 clusters. Any study which is published or planned? Because we have 2 speakers. One is speaking on clustering and one is on AGP. Yes.
I will collaborate. If you do.
Absolutely, that's a brilliant idea. So we should do that. Now, having said that, I would love to see how these different profiles behave, and that would be a great idea. So, Dr. Mazzi, I'll probably catch up with you later regarding that.
I hope so, yes. It would be wonderful. I think also for you to think about it this way, it may also characterize the cluster. Yes. And there may be telltale signs. Maybe there's greater variability, one cluster to the other. And that would be wonderful for clinicians who are making decisions. So it may be even easier in the long run to say cluster, and now they're defined by, and finally, what treatments are most effective.
Absolutely. Having said that, there's just one thing that we did before we did this clustering. We took, we have thousands of people on AGP now at the center. Yes. About 9,000 people. And we went retrospectively to all those who had done AGPs and tried to cluster among that. And we found 3 clusters. Of course, these are glycemic profile clusters. They have nothing to do with our phenotypic clusters. So we had 3 clusters. It's just published in DTT, actually, just accepted. Publications will be out next week, I think. So we have the TIR cluster. We have a hypo cluster and a hyper cluster, which is typically common sense, I guess. But it came out as 3 clusters of retrospective AGP analysis.
Well, my plan is to move to India.
You're very welcome.
Thank you. No, I want to congratulate you and your colleagues at your center. You have, I think, perhaps the largest number of individuals with AGPs. I think the other one is our center in England, which also has been doing this for 5 years now. So I congratulate you on wonderful work, and I look forward to reading the article and hoping to see much more on that.
Thank you. I'll send it to you as soon as it's available.
Thank you. Thank you
so much, Dr. Anjana and Dr. Roger Mazzi. It was a great start of our ideas. Now, we would expect you to join our ideas